Today we're pleased to have Sophie Larsen speaking. Sophie is a PhD candidate in the Ecology, Evolution, and Conservation Biology program at the University of Illinois at Urbana-Champaign. I hope you have a shorter name of referring to your program. That's a lot. It's a mouthful.
Yeah, we call it the PEAK program. It's a mouthful.
That's good. Okay, good. And before I say a little bit more about our speaker, I just want to say I'm really pleased to have a graduate student today presenting. We've had that a little bit. I'd love to see more of it. And so if anybody on the call is a graduate student or postdoc and wants to present their work, please get in touch. But then back to Sophie. Sophie's research focuses on the impact of host heterogeneity on infectious disease dynamics at the population level. And I think that's what the talk is going to be about. And so with that, I'm just going to hand it over and please take it away. I'm looking forward to hearing what you have to talk to us about.
Thank you. Yeah, so yes, I'm in the PEAK program. I'm in Pamela Martinez's lab at UIUC. And today I'm going to talk about some of my dissertation research on host heterogeneity and SARS-CoV-2 dynamics from structural inequity to immune history. So often we think about infectious disease from a very biological perspective, right? We think about infectiousness of a pathogen, virulence, host defenses, things like viral evolution, changing the pathogen over time. And so this framework is like very biology focused. We can think about, maybe the interaction between host immune history and pathogen dynamics. And we started to understand that heterogeneity in these factors is really crucial to understanding disease transmission. So on the right, this is a paper that was published recently from the SHIELD testing program at Illinois. This was a massive testing program that UIUC rolled out across the campuses. And so there was a lot of data to be used. And what they found was that there was a lot of heterogeneity and infectiousness of individuals who were infected with SARS-CoV-2. And trying to understand these heterogeneities can help us to inform model structure and the outcomes in our models. But historically, transmission models have not necessarily taken into account heterogeneity in the sociodemographic experiences of the host. So I've put a couple of papers here that I found particularly inspiring, as I was kind of starting my PhD and getting more into these projects. There's really a socioeconomic divide in computational modeling, and I really like John Zellner's commentary. To make long-term gains against infection inequity, we have to develop a more sociological imagination. Host heterogeneity, especially socioeconomic status, is an old problem, right? There's long-standing awareness that there's disparities in non-communicable diseases, but this gets very challenging to study in the context of infectious disease because there's a lot of parameters that are unknown. Transmission adds a layer of complexity, right? If I have, heart disease, that's my individual problem. I can't give you my heart disease, but if I have SARS-CoV-2, well, then of course I can give that to you, and that complicates, tracing these pathways. And then prior exposure, when you have a population that might have different levels of exposure in different groups, that might complicate trying to understand their risk level. This all makes it a really challenging question. And there have been some, really core advances. For example, models of sexually transmitted diseases, from very early on took into account heterogeneity in the number of sexual partners, for example. What was really unique about COVID-19 is that everyone was susceptible at the same time, and there was no vaccine for the first year. So kind of in real time, we got to watch, unfortunately, how SARS-CoV-2 spread through certain communities at a rapid pace, but not necessarily others. And then we also got to observe how vaccines rolled out and how this, influenced these pathways. So really, what we saw is that SARS-CoV-2 cannot be separated from social and economic conditions. These are some headlines from March 2020 as the pandemic was hitting the United States. Race-related COVID-19 and the collapse of America's welfare state. Where can domestic violence victims turn during COVID-19? There was this big issue, right, because we had to implement lockdowns to try to avert, massive waves, try to flatten the curve. But at the same time, we're sending people home to potentially live with, abusers, which is also a public health issue. And then we have, COVID-19's economic pain is universal, but relief depends on where you live. And across local and national environments, the experience of COVID-19 is profoundly different. So, these headlines are a year into the pandemic in spring 2021. And at this same point in time, we were watching COVID-19 patients die in Jordan because there was an oxygen shortage. In Taiwan, they were talking about living without fear of the virus because they had managed the cases so well. And then, of course, in India at this time, they were experiencing a massive Delta wave that was resulting in just mass death across the country. So I want to link this back to SES. Everyone in this, Zoom room right now has a socioeconomic status, right? So we have a certain level of income, we have a certain education level, some amount of access or lack of access to healthcare and health promoting behaviors. And all of these things, right, make up our socioeconomic status. And when we look at COVID-19, it impacts every single step of the pathway. So early on, we saw that, high SES individuals, they're living in low density housing. They might have a car, so they don't have to take public transit. And they might not even have to go into work because maybe they can do their job remotely. Whereas in low SES communities, a lot of people, were a lot more exposed. They might be living in high density housing or multifamily housing. They might not be doing a job that can be done remotely, like maybe they work in a higher risk setting like a pharmacy. And so their risk of getting infected was much higher. But then when we looked at test results, this is a paper that my advisor put out in Science in 2021. The test results in Chile, they were seeing that low SES groups, when they got tested, had a delay compared to high SES communities and when they got their results back. So you can imagine someone is now out in the community for longer because they didn't necessarily have that result that said, okay, I do have COVID-19 and I need to stay home. And what we also saw is, high SES groups over a long period of time, even before the pandemic, have access to health promoting behaviors, have access to preventative care in a way that, many folks in low SES communities do not. And so this all influences the risk of severe disease. But the access to hospital beds when you need hospitalization is very unequal. So in Chile, one of the things that my advisor, Dr. Martinez, saw in the early days of COVID is that at first they looked at the mortality data and they said, wow, high SES seem to be dying at a really high rate compared to low SES. This is surprising. We would have expected the opposite. But when they did a little bit more digging, what they saw was that in low SES communities, there just weren't hospitals. So people were dying at home. They were dying more, but they were dying at home. And so they weren't necessarily being counted in the same way as high SES groups. So through all of this, what we see is that, high SES experience lower mortality. They're ultimately shielded from many of COVID-19's worst outcomes. And then this was, of course, published, kind of at the beginning or the middle of vaccine rollout. And vaccines introduce kind of an added layer of complexity to these pathways. They might block infection, they might block hospitalization, they might prevent mortality, but how are they going to be distributed, and what communities are going to have access, and how might that change these dynamics? So, I was starting my PhD and learning about all of these socioeconomic factors kind of in real time as SARS-CoV-2 was developing. I came to think of this as kind of like a web of heterogeneity. So now not just looking at the host immune history or the pathogen dynamics, but now also adding in things like socioeconomic status and access to interventions. So the first project that I'm going to talk about today is going to focus more on these two more social factors of SES and interventions. So from the outset, when we were thinking about vaccination and how this might impact these pathways of SARS-CoV-2 inequality, we knew that classic public health theory, suggests that this might not be so good. Vaccine uptake might be inequitable, it might exacerbate disparities. So we have the inverse care law, this classic paper from Tudor Hart in the Lancet, that the availability of good medical care tends to vary inversely with the need for it in the population served. So what does that mean? We know that we have a low SES group who is experiencing high levels of transmission, high levels of hospitalization or severe disease, high levels of mortality. And what we think is going to happen based on things that have happened in the past, is that that population is probably the least likely to get the intervention that they desperately need, this vaccination. And then, when we put this in the context of fundamental cause theory as well, we can think about how innovations have the potential to contribute to the production of inequality. So if I already know I have disparity between these two groups, and then I introduce a layer of vaccine disparity, I might make that underlying disparity in transmission or mortality more pronounced. So to try to answer the question of how vaccines were distributed, we first collected data on GDP and first dose vaccination for 161 countries. And the results look, a lot like we might expect. If you look at, the GDP per capita on the x-axis, and then the percentage with at least one dose of the vaccine, the y-axis, what we see is that it's pretty much a straight line by a country's GDP and then their vaccine coverage. And what we also noticed is that in the bottom left quadrant of this graph is most of the African continent. And so unfortunately, we saw that, yes, at the country level, vaccine distribution has been very unequal. But then we wanted to understand not just between countries, but within countries. It's one thing to say, I expect that the United States is going to have a lot more vaccine coverage than low and middle income countries because it's a wealthy country and it can acquire vaccine doses. But then what about within the United States? We know that we have market wealth inequality within the United States that might also affect how, once those vaccines are acquired, how are they distributed or taken up by individuals? And so to understand these subnational trends, we collected subnational temporal data for 34 countries and 57 states. The states here are in the US and Brazil because we just had so much data that we were able to split it that way. And this map is showing, where did we have data at a high spatial resolution. So the darker blues are we had really good high resolution data. These lighter colors are, less than 50% vaccinated. So we really didn't have enough data to make conclusions. Or we weren't able to find the data for those countries. And what we saw was that subnational vaccination is highly unequal by SES. So on the right, I'm showing the week of vaccination, right? So like week 0 is when I start rolling out a vaccine in a country. And then on the y-axis, we've got coverage with at least one vaccine dose. And so if you look at Cape Verde, the dashed line is the low SES group. The solid line is the high SES group. There's not, so much disparity, but it's around, 10% by week 40 or 50. And we also noticed Cape Verde has this really steep increase. They really rolled out vaccines very rapidly once they started, and then kind of plateaued around, maybe 60% vaccinated in the country. If you look at Malaysia, on the other hand, they have a really slow increase. They plateau quite a bit higher, especially in that high SES group. But there's quite a bit more disparity. And in fact, California, in the bottom left, is the worst one we saw. Out of all the countries or states that we looked at, they have greater than a 40% coverage disparity between the highest and lowest SES groups in California by, sort of the end of vaccination. And when we looked at, all the states and all the countries, what we saw is that in about 80%, a little over 80% of the places that we looked, we saw subnational vaccine disparity in favor of high SES groups. That, stuck out to us when we were looking at this data is that it looked quite a bit like a classic resource consumption curve like you might see in ecology. So this like functional response on the left. So this is, traditionally you're looking at density of a prey population against the number of prey that a predator is going to consume. And there's different types of functional response. And what we noticed is it looked quite a bit like a type 3 response, which is used classically in ecology, but also in enzyme kinetics, in life expectancy curves. And so we thought, well, let's try to fit, a type 3 functional response to the data and see what we get. And on the right, the first plot I showed, actually these solid lines and dashed lines are the fit data. Behind it, you can kind of barely see there's the little points. Now that I've zoomed in, you can probably see a little better. There's little points that are actually the observed data. So this fit remarkably well to what we were observing in each country. And why is it useful to fit something like this? Well, we can get some really key parameters that allow us to characterize what a vaccine intervention looks like in a country. So we get this parameter VM that tells us the maximum vaccinated. So this means like if I'm going to keep vaccinating forever, 60 weeks and beyond, I'll eventually hit this plateau of VM. And then the WH is the week at which I reach half of VM. We call it the halfway week. So if I know that I will eventually get to 80% vaccinated in my population, then the halfway week is the week that I reach 40% vaccinated, half of my potential. And then K tells me the trend shape. So a higher K, like 2 or 3, might give me something more like a type 3 response. As K gets lower, we switch more into something that looks more like a type 2 response. And so we fit this for all the places we looked at. And we were able to classify the trends into 2 groups using Gaussian mixture models. So this dark blue we call sigmoidal, the teal we call concave, and I'll show you why in a minute. But these plots are basically showing you, comparing the high and low SES parameters for each country as a point. And what we see is that the shape of the functional response is very, very clustered. In fact, there's not a single country where we saw that low SES has one shape and high SES has another. No, they always fall in the same cluster. The halfway week is a little bit more distributed, but we still see some clustering there. It's fairly linked to the shape. And then the potential maximum vaccinated is kind of all over the place. It's a little higher for the sigmoidal group, but in general, you could be concave and have a high level of vaccination. You could be sigmoidal and have a low level of vaccination. And so on the right is, the average for each group, the average trend for each group by SES, and then by the concave and sigmoidal type. And what we saw is that, on average, again, sigmoidal is reaching a higher potential maximum vaccinated if we let vaccination go on and on. But we noticed this kind of critical period before week 30, where even though concave is going to be less vaccinated at the end, they seem to be quite a bit more vaccinated for the first 30 weeks because the halfway week is faster and they're ramping up much more quickly. And so we wanted to understand what is the impact of these different trends, both the SES disparity in vaccination, but also, these clusters that we weren't expecting to uncover. What is the influence on the disease dynamics? And so we incorporated socioeconomic status into a classic transmission model to try to explore the impacts. So this is a model that, susceptibles can become exposed through contact, which is stratified by socioeconomic status. Once exposed, they become either infected with symptoms or they can become asymptomatic. If they're asymptomatic, they'll eventually recover. But if they are symptomatic, we assume that they have, some probability that they recover, but otherwise, they will die in our model. And that's also stratified by SES. And then finally, we have an SES stratified vaccine intervention. And so this is kind of the first loop of the model, but I'll show you the full diagram here. We have, a first class where you're totally naive. You haven't had an infection or a vaccination. But once you've had either of these things, you move into a second SEIR loop and kind of stay there at a higher level of protection. And so what did we see? Well, concave trends seem to be the most important factor in averting deaths, even greater than SES disparity. So what is this plot showing? The bars are showing the total deaths that we see under a certain model simulation. The purple is if I don't vaccinate at all. No vaccine is ruled out. And then in the next group, this is our worst case disparity. We looked at all the countries and looked in each cluster, and we looked for what is the worst disparity that we see. And then we implement those vaccine parameters in the model. And then we have an average disparity. Again, that's just the average of what we observe. Then the equity average is saying, well, if my low is here and my high is here on average, what if I kind of bring them together? So high is going to be a little less vaccinated and low is going to be a little more vaccinated. And then we have an equity best case. And this is where, we say, well, here's high SES and I'm going to bring low up to high. This is, a very hard thing to do potentially, but it would be kind of the best case of resolving this disparity. So if we move from the sigmoidal bar in the worst case disparity scenario, from the outset, we're averting 37% of deaths. If we move to the equity best case, we're averting 53%. So that's a 16% change, percentage point change in the number of deaths that we could avert. But if I stay in the worst case disparity scenario, and I simply move from sigmoidal to concave, I can avert an additional 27% of deaths. So we were really surprised by this because I at least, expected going into this that averting the SES disparity was going to be the most important factor, but no, it seemed to be the shape. So then we did a sensitivity analysis. In the plot that I showed in the previous slide, right, the timing, the max coverage, the concave versus sigmoidal, these things are kind of linked. We're changing them at the same time. But in this plot, we're unlinking them. So on the x-axis, I've got the week at which the rate is half of VM, my halfway week. On the y-axis, I'm changing the potential maximum vaccinated. And then the left-hand plot is concave, the right hand is sigmoidal. We're just fixing a K. And here what we saw is that the deaths averted by vaccination seem to be the most sensitive to the halfway week, right? So as I move across a row, especially in the sigmoidal group, I'm going to get quite a big change in the gradient of deaths averted. But as I move up and down a column, I'm not making that much of a change. So what we're seeing from this is that the speed of vaccination seems to be more influential in the dynamics, that early speed, than the eventual coverage level that I reach. And the white dots here are the observed countries. And so you can see, like in the sigmoidal group, the observed data of the sigmoidal group is falling in an area of the parameter space that has, a much later halfway week on average versus the concave. And so this is the full analysis across all the equity and disparity metrics. But generally, the trends that we saw, that halfway week is the most important, were consistent across all equity and disparity scenarios. So promoting vaccine equity averts deaths. When we look at the best case equity and the worst case disparity, and we compare them, we compare the deaths averted. In a concave or a sigmoidal scenario, right, you can avert potentially up to 25% of the deaths by moving from your worst case inequity to your best case equity. But these dots, these observed countries, most of them are not falling in this area of the parameter space. We're more likely going to get 10 to 15% or maybe 15 to 20% averted by addressing disparity. But what we also see is that improving vaccine shape can avert a large portion of the deaths, even if you don't change your halfway week or your VM. And so in this case, what we see is that there are some situations, some areas of the parameter space where you have very, very low halfway week, where it might be not optimal to move from sigmoidal to concave. But what we observe is that, number one, most countries are in an area of the parameter space where the concave dynamics are optimal. And number two, when we look at the extreme trends, at the extreme end of these phase diagrams, what we see is that in some cases, the sigmoidal type, just because of how the parameters are shaking out in this extreme end of the spectrum, is actually faster in that critical early period. So our conclusion is the same, that you really want to make your shape the best it can be in those early 30 weeks. So remember, shape and timing are clustered. So even though, we might have similar effects when we just change parameter K versus changing equity and disparity, we can actually make a jump in both timing and shape, which are clustered together, and this nets the greatest benefit, like I showed in the bar plot earlier. And what was especially surprising to us, we saw this and we thought, well, okay, but how realistic is it that I can tell a country, change your vaccine shape? But what we actually saw is that there's no significant association between timing and shape and GDP or wealth inequality. But there's a significant association between the maximum coverage and the level of wealth inequality in a country. So what we think is happening is, it might be very, very challenging to change your vaccine inequity because you already have entrenched wealth inequality that's, obviously hasn't gone away. It's here. And that's highly correlated with your vaccine disparity. So it might be really hard to, try to close that vaccine gap. But if you're able to improve the timing and shape, which is decoupled from your wealth inequality, then you might still be able to overcome the impacts of the disparity. So the upshot is increasing the speed for everybody seems to mitigate the impacts of disparity on the overall mortality from SARS-CoV-2. The shape and speed of early rollout has a crucial impact on disease outcomes. It seems to be accessible. It can overcome the effects of disparity. Okay, so what I just talked about was a project on vaccines, but of course, by August 2022, we had these bivalent booster shots that were starting to come out. We were moving beyond primary series vaccination. interested at this point because when we had the primary series vaccine, we were dealing with people who had very little immune history. So, at most, you might have had like a wild type infection, or if you got vaccinated, very late, maybe you had had Delta at that point. But by the time bivalent boosters were rolling out, we'd now had 3 different variants, and we had people with different levels of vaccination. And we realized that exposure histories might be really different throughout different populations. So, if you imagine we might have an individual with low socioeconomic status who couldn't work from home in the early pandemic. So maybe they're more likely to have acquired an early pandemic variant, a wild type variant. And then they may or may not be vaccinated, right? We saw from those curves, like, maybe if you're in California, you didn't get a vaccine because there was so much vaccine disparity. But a high SES individual who got exposed to a later strain, maybe they worked from home, but they were starting to relax around the Delta wave. And so they end up getting Delta, and they're most likely vaccinated against COVID-19 based on, the trends that we saw. Beyond the distribution of vaccines in terms of like who is eligible to get a booster, why do these exposures matter? Well, because at the same time we were rolling out bivalent boosters, we were starting to see that exposure history can have really unintuitive impacts on your level of protection against emerging variants. So this table, the little cartoons on the side are showing an exposure history. So, in row C, I've had a vaccine and an Omicron infection. And these individuals seem to be really protected against the ancestral types, against Delta variant. But then when they get to BA1, they seem to be still really highly protected. If we look at row E, this is someone who had a wild type infection first, then got a vaccine, then got Omicron. And they're still very well protected against the wild type variant, against Delta. But when we get to BA1, they suddenly have very low infection, even though they have sort of more exposure history, even though they're similarly protected to, ancestral and Delta. And what seems to be happening here is a sort of imprinting effect where, you've seen so much wild type and then you get Omicron and your immune system starts back boosting those wild type antibodies and doesn't necessarily mount a robust response to Omicron. So in these cases, having a wild type exposure might actually be sort of bad for you. And so what we wanted to understand was how does SES heterogeneity and who saw, what, whether it's a variant or a vaccine, and when they saw it, affect the booster impacts. And we also wanted to know, in this context, does the booster formulation matter? So if I give you a bivalent versus a monovalent, depending on your history, you might have a different response. And so, going back to the web of heterogeneities, you think about SES and interventions and access, but now we're also going to add back in pathogen dynamics and host immune history. So on the eve of bivalent booster rollout in the US, the WHO asked for models that could address the potential impacts in LMICs. And we really wanted to look at this question, combining socioeconomic status with exposure history and booster formulation. This was a collaboration with Alicia Cray. Formerly, she was a faculty member at UIUC, but now she's at the Gates Foundation. And we developed this agent-based model that's stratified by SES, by age, by immune history, and by country. So this thing is kind of a beast. So the model structure, people start as susceptible, they get exposed through contact, they become infected, and then they recover, right? And those rates are stratified by socioeconomic status. And then we also have, vaccines and boosting implemented in the model that are also stratified by SES using the trends we found in the previous work. And something I'll note about the R class that's a little bit different about this model and the previous one is that we're assuming that recovery is not sterilizing. So individuals in the R class, they recover into a very high level of protection based on, their immune history, but they eventually wane back down into a lower level depending on how many exposures they've had, and then they're sort of more susceptible. So it's more of like a recently recovered class. And so then we also have stratification by age. So again, your risk of dying from COVID-19 stratified by age. The boosting is stratified by age. We're not allowing children to get boosted in this model because the bivalent booster wasn't available to children in the countries we looked. And then we have immune history. So your risk of infection, your risk of dying from SARS-CoV-2, and then both your eligibility to get a booster, but also your level of protection gained from a booster is all stratified by immune history. So I'll kind of explain how we did this. In the upper right, this is showing basically on the rows, we're showing someone's immune history. So the first row, I've had just a vaccine. The second row, I've had just a wild type infection. And then as you go across, we've got different variant waves. So against wild type, you might have one level of protection, a really dark color, because you had wild type and you're really well protected against it. By the time you get to Omicron or Omicron star, which is sort of our hypothetical new variant in this model, you might be pretty poorly protected because of the distance. And so we estimated this using antibody titers, neutralizing antibody titers from sera. This is a very hard thing to estimate because it's hard to know what people have had, right? So the best we can really do here is to look at neutralizing antibody titers and try to convert them into sort of a relative estimate of protection. And this is the whole table. So we're able to really kind of understand relative protection for a range of histories, natural histories, hybrid immunity, and then vaccine-only history. And then it's also stratified by country. So we looked at India, Ecuador, and Malaysia as kind of benchmark countries. So for each country, we implemented the true vaccine trends that we saw, beginning in the wild type wave and ending at the beginning of the sort of new variant, Omicron star. And then we, tried to sort of qualitatively match the relative wave size in each country. So I want to be really cautious here because we didn't fit this data. Number one, with an agent-based model of this complexity, it would have been, we can't fit this data. It's not possible in our model. But also because, we're not trying to capture necessarily 100%, this is what I know happened in this country, but more we're trying to use this as a benchmark for how diverse the immune landscape might be. For example, in Ecuador, they have really low wild type, fairly low delta, but they had a bigger Omicron wave. Whereas in India, they have this really unique delta wave that kind of dwarfs their other two waves. So this kind of diversity is what we were trying to get at with these three countries. And so the model simulated landscape of immunity is quite diverse. If you've ever read a CDC like variant of concern proportions plot, that's essentially what this is, except we're looking at history prevalence rather than the prevalence of a given variant. And what we see is that, it is quite different across our simulations of these three countries. If we look at month 18, for example, Ecuador has just a huge amount of the vaccine-only group, but and they have a lot of naive individuals, but very low natural infections or hybrid immunity. In Malaysia, we've got tons of hybrid immunity, tons of vaccination. Malaysia and India have a lot more delta going on. Of course, as we get later in the simulations, India keeps that really big proportion of delta histories, whereas Malaysia and Ecuador get, more distribution and a lot more Omicron. And so we developed a range of booster scenarios based on the responses to primary series vaccination. Again, it's very hard to say, especially given the data we had in August 2022, but even now, there's no clinical trial data that says, I know this person got Delta and then they got a vaccine and then they got Omicron. And so I know exactly how they're going to respond to a booster in this population level study. That doesn't really exist as far as we know. But what we are able to do is take, responses to primary series vaccination by history that we see in the original antibody titer data and try to use that to predict, what might be happening when you give someone a wild type formulated monovalent or give them a bivalent, or here we've also considered a hypothetical Omicron monovalent. And then we implement boosting 60 days prior to the new variant wave. Boosting can avert a wave, particularly if the infectiousness of a new variant is restrained. So we consider two scenarios. Number one, we have the immune escape just in the antibody data. We push Omicron star a little bit further away in terms of protection from Omicron. But we also consider that, a new variant might have itself inherently evolved to be more capable of infecting an individual. What we see with previous variants is about a 30% increase in the secondary attack rate. So we have kind of two scenarios here. We have one where you have a 10% increase, you're 110% of the infectiousness of Omicron. This is more of a conservative scenario. And then we have a 130% scenario, which is a little bit more, like what we see with previous variants. And so again, in Ecuador and Malaysia, we can, almost even get dyad if we implement boosters, no matter what booster we're implementing. In India, in a 130% infectiousness scenario, we're still going to get a wave regardless of whether we implement a booster. And then we looked at the deaths averted, and these were a little bit unexpected. So these bars are showing the number of deaths that you avert per 10,000 when you move from a no boosting scenario to a given booster. And first of all, in the 110% scenario, there's really not much of a difference between any of these three boosters, this monovalent, wild type, Omicron, or bivalent. There's just not much of a difference. But also we were surprised that the Omicron monovalent didn't perform as well as maybe we expected. So yeah, again, so there's very little difference in this 110% scenario. And then when we look at 130%, the jump that I can make going from a no boosting scenario to a monovalent scenario is, here, this orange line, this is my jump. And then when I jump again to a bivalent, I have very much a diminishing return. The impact of sort of upgrading my booster is very small relative to the overall booster impacts of just implementing a monovalent. And then again, we were really surprised that the monovalent Omicron was really not performing very well compared to the wild type monovalent. And so, that was for one country, but when we look across all the countries for Ecuador, India, and Malaysia, we see some different patterns emerge. So in both Ecuador and Malaysia, we see that the Omicron monovalent is performing not very well, but in India, it does seem to be optimal to the wild type monovalent. And the reason that we think this is happening is if we think about, those history prevalences at the beginning of the Omicron star wave, in India, we're mostly looking at individuals who have a Delta history or maybe a vaccine history, whereas in Malaysia and Ecuador, there's already a lot of Omicron-induced hybrid immunity. And so what we think is happening is, in India, they're sort of lacking this immune history that by giving a wild type, by giving an Omicron monovalent, you're introducing that history to this population. But in Ecuador and Malaysia, maybe they already have it. Now, agent-based models are versatile, but very computationally intensive. Our agent-based model runs for 20 minutes in one simulation because there's so many cross-checks it has to do across all these different individuals and their characteristics. And then we have to run it 500 times to get reproducible results. So that's kind of prohibitive in terms of doing like large-scale sensitivity analysis or trying to understand how other countries might look. So Alicia Cray implemented a second model. This model includes socioeconomic status and age, just like the first one. It includes primary series vaccination and booster vaccination. And then it takes into account hybrid versus natural immunity, but it doesn't look at specific strains. And the advantages of this model, it's an ODE model. It has a really fast runtime. So we can look at a much wider range of scenarios. It's also seeded from the ABM. So, Dr. Cray, she takes the data that we generate on history prevalence, and for each country sort of converts that into a cross-protection parameter that says, how well do I expect the immunity that this population has on average will overlap with the variant that's circulating now. And also she's able to include age stratified contact rates, which unfortunately we're not able to include in the agent-based model just due to the complexity that we already have. And so this is her model structure. We have the top row is people with no natural infection. The second row is people who've had, a prior infection. Then we have unvaccinated, primary series, and then booster vaccines. And what we see is that, the infections in the ODE model are projected to be a little bit higher, but the trends are similar in general. Implementing a monovalent and a bivalent booster can avert quite a bit of the peak that you would see in a no booster scenario. And then when we look at a sensitivity analysis, so just to kind of explain this grid and what we're looking at, On the x-axis of each of these little squares, we're looking at the prior immunity in a population. So if I have 30% prior immunity, that means before I started the model, 30% of my people had had an infection. And then the cross protection, again, is how well does the immunity in this population overlap with the currently circulating variant. So if it's 0%, that's like a complete immune escape. And then if I have 90%, I'm pretty good to go. I have very good overlap with what I've seen and what's happening now. We've got the bivalent and the monovalent. We've got the 110% infectiousness, 130%. And what we see in the deaths averted is that cross protection and prior immunity have a similar impact. So, if a lot of people have been infected, even if the cross protection is low, I still might be able to avert a fair number of deaths with a booster. As we get to, no prior immunity and no cross protection, this is where we see the biggest boosting impacts. When we have really high cross protection, really high prior immunity, this is where we see the least booster impacts, which is intuitive. And then the black dot here is where the true parameters for Ecuador really fall, seeded from the ABM. And when we look at all of the countries, they're fairly similar. We get a lot lower impacts in India because number one, well, really the main reason is that their boosting is a lot lower. And then in Ecuador and Malaysia, the dynamics are quite similar. So we're really seeing that the highest impacts are at the lowest levels of prior immunity and cross protection, as we would expect. And then we wanted to make a comparison. So, back when I was showing the agent-based model, I showed that arrow, right? This is how much I gained from going from no booster to monovalent. And then here's how much I gained going from monovalent to bivalent. I wanted to measure this as kind of like, what are my diminishing returns? Like, if I upgrade from monovalent to bivalent, am I getting more of a gain than I did from just implementing a booster? Or is it a diminishing return? And so how we're measuring this is we look at monovalent deaths minus the no booster scenario, right? That's our X, that's our jump from no booster to monovalent. And then our Y is our jump from monovalent to bivalent. If Y minus X is bigger than 0, then the gain that we get moving from a monovalent vaccine to bivalent is bigger than the gain we get moving from no booster to monovalent. So this is a little bit tricky, but the way to think of it is as a diminishing return. And what we see is for example, in Ecuador, for the true country parameters in Ecuador, we're getting diminishing return. Every time I make a jump, I'm getting a diminishing return. But if we had pushed the cross protection and the prior immunity just a little bit lower, we would be in an area of the parameter space where really you should be upgrading to a bivalent booster, because just moving from monovalent to bivalent does even more than boosting with a monovalent itself. And we saw similar patterns across these countries. It's especially pronounced in Malaysia. And so what's really interesting here is that, in all cases but one, the country-specific parameters are falling in an area of the parameter space where you're getting diminishing returns. But if we pushed, just to a little bit lower cross protection or a little bit lower prior immunity, we would see really, really big impacts of the bivalent booster. So to me, this kind of helps explain why we were seeing an agent-based model that had a similar parameterization, that the bivalent isn't having much of an impact. This was really surprising, based on just what we knew about the clinical trial data from the bivalent and the fact that the bivalent has, more overlap with what was circulating than the monovalent vaccines. But what really seems to be happening is that, we're looking in populations that already have a really high level of natural immunity, and in particular might have exposure to more recent variants. And so what our takeaway from this kind of is that in places with a high natural immunity, just boosting on its own is maybe more important than what formulation you pick. So again, it's more important to roll out a booster than necessarily which booster you roll out. The booster impacts can vary across countries. What formulation is optimal is kind of seems to be influenced by the prevalence of the hybrid Omicron histories in a country. But then really I want to emphasize that in a country with low prior immunity or immunity that really doesn't overlap with existing variants, you might have a much bigger impact from the bivalent boosters. So it's not to say that, the bivalent boosters are useless and you shouldn't use them. It's not even to say that, these countries shouldn't acquire a bivalent booster. But, more what we think is encouraging is that in a country that has a high degree of prior immunity and maybe economically can't acquire bivalent boosters, your monovalent is still going to do a pretty good job. And then importantly here, we didn't consider predictive boosting. This is something that's done for flu. And when we see this poor performance of the Omicron monovalent, and we look at populations that have seen this already don't seem to do well with this booster. This kind of suggests to me that maybe predictive boosting is the next step with COVID-19, is that we really need to be looking forward to new variants rather than trying to boost with what we've seen already in the past. And so, what can we learn from these models in general? Well, host heterogeneity at the individual level, coupled with mathematical models, can inform interventions at the population level. And understanding the interactions of host heterogeneities can help us to kind of unlock unintuitive insights to inform future policy. Right? If we didn't do this modeling work, we might not have ever guessed that in certain populations, a bivalent might not be actually that much stronger than a monovalent at the population level. So we can have a lot of insights there. I want to acknowledge my collaborators, my advisor, Pamela Martinez, Alicia Cray, all the folks that worked with us on the vaccine inequity paper that I presented first, as well as the WHO paper, and my funders. And with that, I am happy to take any questions.
Very nice talk. Thank you. This is fascinating. A lot of questions. I want to open up to the audience. If anybody has any questions, please raise your hand or put something in the chat. I will start something off. Going back to the first part of your talk where you described the equity.
Sure.
Do you think there's, or is there any room for bringing in some other markers of equity disparities? And what I'm thinking is perhaps something like rural versus urban kind of demographic patterns. And have you given any thought to that?
Yeah, absolutely. There's a few things that I think are really worth bringing in, and we're trying to bring in a future project, which I'll touch on in a minute. But yeah, I agree. I mean, when we looked at vaccination, for example, like one of the very odd things we noticed is that in a state like, for example, North Dakota, there's no vaccine disparity. And we were puzzled by that because we thought, everywhere we're seeing vaccine disparity, but in some of these states, even the low SES might be more vaccinated than high SES. And this was very puzzling to us. But then the thing that we've been thinking about a lot is that maybe this has to do with political affiliation, for example. If you're in a state that has very, very high opposition to vaccination, just on a political level, then maybe just nobody's getting vaccinated, whether you're low or high SES. Your point about urban and rural kind of falls along the same lines. Like if we think about, access to vaccination centers in rural communities, maybe if you have to drive 2 hours to get a vaccine, you're just not going to do it. And so I think those factors are really important. We also saw disparities in terms of race. We didn't look at this specifically in this paper, but in the United States, there's huge COVID-19 disparity along racial lines. So we have a new project that we're working on with Shield, Illinois, that testing program that I mentioned at the beginning. And we have access to all their testing data by, income and zip code and race and age. And we're hoping we can try to use that data to understand, what are the disparities in intervention beyond just socioeconomic status? And also, how might those vary across pathogen, right? I don't necessarily expect to see the same patterns with flu vaccination that we see with SARS-CoV-2.
Sorry. There's a question here that I'm not quite sure how to answer what this question is getting at. So if the person can clarify, that would be great. But the question was, can you help us with the mathematical models? And I know that's a hard one to ask, but I want to pass it
maybe on. I wonder if this person means understanding like how we implemented.
Sure. Why don't you try that? Say something about that, and maybe that'll help.
Sure. So so this is a more complicated version of the vaccine inequity model diagram. This was implemented in R using DSolve. We have just a simple ODE system. And we look at, all these different factors. So we have our asymptomatic class, our symptomatic class. And then of course, we move from S1 to E1 as we get exposed, to I1A, I1S as we get infected, and then to R1, and then people move kind of through the second diagram once they've been recovered. Implementing an ODE model has advantages. It's a lot faster. We were able to run a huge sensitivity analysis for this model that we really can't do with an agent-based model. On the other hand, with the agent-based model, what's really nice about it is you can store a lot more information about an individual, right? Like in an ODE system like this, we're sort of assuming like a well-mixed population, and we're not necessarily tracking one individual and their trajectory through time. But with something like immune history, that's a little bit more important because people have just such diverse and unique histories that to really get at that question, we need to know at the individual level what is happening. But then the disadvantage, right, is it's stochastic. So you got to run it a bunch of times. It's super slow because it's tracking all this information. So it's a little bit harder to work with. So I don't know if that helps get at that question a little bit.
Yeah. Yeah, I think you got that. The person said yes, it answered the question. On that note, you mentioned the models that you can't run because they're agent-based. And I assume that's just because you're going from minutes to days or more to run this stuff.
Yeah.
I mean, is there any prospect of or utility? I should both of these things. Any way to do a more constrained version of the problem with something agent-based that would let you get into more of these complex dynamics?
Yeah. I think so. I have a couple thoughts because I have wrestled with this model for like a year and a half, and I've been so frustrated with how challenging it is to run things. I think, if I could do this model all over again, I would probably learn Julia and implement it in Julia because, there's a computer scientist who works with some folks in the PEAK program and in related programs who's been doing some modeling work. And what she's really started to show is that when you implement things in Julia, you're cutting your runtime by like 100th or 1,000th. So I think, if I could go back and do it again, I would probably use a different language to implement this model. The other thing I would say is, we could try to develop a constrained version where, maybe we don't group variance as stringently, maybe we just update the parameters for each wave, but we take kind of more of an average history protection. But I do think it's challenging because I think, through the year and a half, we whittled down more and more. We started with age stratified contact and we were like, well, it's just not working. It takes hours and hours to run. I'm sure someone with more computer science knowledge could do a better job sort of like narrowing this down into a faster, more efficient model. But yeah, there's definitely more to be done with this model in the future in terms of optimizing it.
Yeah, I'm imagining just sort of maybe it's even constructing a fully synthetic population that was limited enough in size, but maybe still had the right dynamics. It's hard to
right.
And you read the problems of ecological validity there. I understand that, but just
yeah, that's definitely true. We're running right now. We're running on 100,000 individuals. My dream would be to run on like 1 million, but that takes a couple hours. And so for the sense of just like getting, getting results, 500 runs over an hour or 3 hours each is just not feasible. We could try smaller populations like 50,000 or 20,000 and see, are the overall dynamics changing? And can we try to do some more complex analysis on a smaller population with the caveat that, yeah, there might be some ecological problems with doing that. But it still might, give some insights.
Mm-hmm. Okay, great. I'm trying to answer something to the question here. I guess then I would also, since there are no other questions, I'll go and ask the obvious question. What are your next plans?
What are my next plans? Well, we're working now I'm working on a couple different things. One is a project that looks at seroprevalence, so using more of this like neutralizing antibody data to try to understand the dynamics of a pathogen. I'm really interested in a question of, how do seasonal coronaviruses interfere with these dynamics? So this model that I just showed was, SARS-CoV-2 variants, different variants. But the sort of the cousins of SARS-CoV-2 are, the seasonal beta coronaviruses that are circulating among us, even before the COVID-19 pandemic. And there is some emerging but conflicting evidence of how those viruses might kind of interfere, either be protective or, give you a really, really bad time. If you've had a common cold and then you get SARS-CoV-2, maybe you're actually worse off. Some of that might help to explain why we're seeing, less severe disease in children. So I think understanding that question is very interesting to me. It's something that was kind of beyond the scope of this paper. But, as we look at things like, okay, well, we're implementing low mortality for children and high mortality for adults, but why is that happening? Why is that the case? And I think it does go probably back to this immune history component to some extent. So that's one project that I'm working on. And then a second project is, the one I mentioned on thinking about other sociodemographic factors that might inform disparities, not just for SARS-CoV-2, but also for RSV, for influenza, across seasons.
Yeah, absolutely. That sounds fascinating. We did have one request in the Q&A to somebody who wanted to possibly discuss collaborating with you. So if you could put up your contact information.
Yeah, absolutely. Let me put my contact in the chat.
Great. And fantastic. Thank you. So I think people can see that. If not, did you have a title slide with your?
Oh, I don't think I put my email on the title slide.
All right. So
yeah, I don't think so.
folks, if you need to get in touch with Sophie, just contact questions@midasnetwork.us and we will share that information. So I don't see any further questions. We're just about at the top of the hour. I do want to also I want to thank you for the talk. That was really interesting stuff, and I'm looking forward to hearing more about this. Also want to mention to you and other trainees who might be on the call, if any, that we are really seeing a number of folks who are coming to us at MIDAS with positions that they're trying to fill, postdoctoral research positions and similar things. And so if you're in the market for that, please do take a look at the MIDAS Network site and our weekly newsletter, and you'll see these listings. And I think it is definitely a good time to be looking for positions in infectious disease modeling. And so please, we want to help people find positions and fill positions as need. So please do take a look if you're in the market. And with that, I just want to say thank you to the speaker. This is a really nice talk. And thanks to everybody for a good year of MIDAS webinars, and we will hopefully see you in 2024.
Thank you so much for having me.
Great, thanks. And one final point is the talk will be up on our YouTube site, hopefully early next week. Take care, everybody. Have a great new year.
Bye.
Bye.